So welcome, Dr. O'Malley.
Hello, everyone. How are you guys all doing? I'm happy to be here. Thank you, Susan, for the invitation.
Yeah, we're thrilled to have you. And we have kind of a jam-packed schedule, so I'm going to jump right in if it's okay with you. We're going to talk tonight about your research into prognostic indicators, which I think is, at least for me personally, very, very exciting, even if it is a little bit deep dive scientific. And then we'll finish up our discussion about itch. And if we have enough time, we'll talk a little bit about how to manage infection with cutaneous lymphoma.
Sounds excellent.
All righty. So maybe let's get a little context for talking about your research project and the prognostic indicators. So how do we determine who might progress, whose disease might progress or not today? How does that usually work?
Sure. So that's a very good question, and there's a lot of different ways, but the primary way that most clinicians use to determine prognosis is to give the patient a stage when they initially present to your clinic and the diagnosis of CTCL is actually confirmed. And that is using a staging system called the TNMB. And I won't belabor exactly how that is done in the specifics of it, but generally it is the amount of body surface area that the rash affects your skin, and whether there is blood involvement, lymph node involvement, or any other solid organ involvement. Okay, so that is the initial stage, depending on which factors you actually meet for that. And your initial stage, which can be anywhere from a thing called stage 1A, which is the earliest stage, to stage 4B, which is the latest stage. After looking at thousands of patients and how they did in outcomes, we are actually able to see what 5-year, 10-year survival rates are. And so that is usually how we discuss with patients their prognosis when they initially present to us. Then subsequently, there's been some more research-oriented studies, because we all know that certain patients in certain stages, while some of those patients within the stage may do well, other patients may actually go on to have progressive disease. So we need more specific markers of how to better stratify our patients. So one of those research studies was, the prognostic index was called the CLIPI, or the Cutaneous Lymphoma International Prognostic Index. And that looked at a variety of factors, and it was actually split into 2 indices, one for early stage patients and one for late stage patients. And that essentially is a point system based on age, based on sex, and then it depends whether it's the early or the late stage, but things like plaques or follicular tropism, or whether you have evidence of blood disease, and you get points, and that stratifies you into a low risk group, an intermediate risk group, or a high risk group. And you have certain percentages of risk of progression for those. Other studies that have followed have generally been able to validate those findings, but there have been some studies that were not able to. More recently, there is now the PRO-CLIPI. So this is the Prospective Cutaneous Lymphoma International Prognostic Index. And this is an international consortium with 26 to 29 international centers and thousands of patients, in order to see if we can determine better prospective markers to be able to risk stratify our patients. So that is currently the current methods of how we help to prognosticate the patients, but it really does fall back to the clinical exam. So we know patients that have a higher surface area of involvement or the presence of plaques, our senses go up a little bit that those patients may have a little bit of a higher risk of progression than someone who has flat disease with very low surface area involvement.
Right. So, but even some of those folks, I just use myself as the example, who was stage 1A when I was first diagnosed and was treated and was okay, and then my disease progressed over the course of 5 or 6 years. But there was no way to be able to determine my risk of progression at that point versus someone else who looked similar to me, right? So that's what you've been working on in trying to find a more scientific way using newer technology to see if there are specific markers that may show that someone has a higher risk of progressing than someone else. Is that sort of a correct
Yes.
layperson's perspective?
I think it's a great perspective. And so one of the really big unmet clinical needs that we have in treating patients with this disease is better risk stratifying, or better able to prognosticate patients like yourself that are stage 1A or stage 1B. And are there markers that we can use that can potentially, ideally, when a patient walks in the door, the initial biopsy that confirms cutaneous T-cell lymphoma, can we find features in that biopsy that will help to tell that individual 5-10 years from now, what is your risk of progression? If we can identify a reliable method of doing that, then that really changes the kind of paradigm of how we treat patients, whether we treat them potentially more aggressively, whether we start discussing the possibility of a stem cell transplant earlier on disease, or even just more basic, are we then able to better our clinical trials by putting patients at the highest risk of disease progression in those clinical trials to really be able to test how new therapies work.
Wow. But we're not there yet, but that is really what you've been working on, right?
Yes. So our research essentially, we first had the question of, are there better ways that we can use to identify patients at risk of progressive disease? So the first thing is we actually had to identify a cohort of patients, a large number of which exhibited stable disease, and then hopefully equally large number of patients that developed progressive disease. And the other key aspect is, since cutaneous T-cell lymphoma takes a long time to progress, we needed a long time of follow-up in order to make sure that the patients that are in either of those groups truly fell into those categories of stable or progressive disease. And we hypothesized that there would be features within that initial skin biopsy, again, that I mentioned earlier, that could actually be predictive of disease progression. And that's where some of the newer technologies that you mentioned were used to see if we could actually tease out what those features are and whether we could find a consistent finding among these patients that would help to identify patients at risk of progressive disease.
So maybe you can talk a little bit about that process and the technology that you've been using and why that makes such a difference.
Sure. So two of the technologies that we have utilized, one, and I'm going to try to make this as followable as possible for the audience, but one is called high throughput sequencing of the T-cell receptor, and the second is called multispectral immunofluorescence. And taking a step back and thinking about what we would like to do is really focus on the skin biopsy. And since this is a disease of a malignant T-cell, so generally the T-cell, there's one T-cell that is a cancer cell and is no longer following the general rules of growth inhibition that one can find in the skin. So that T-cell outgrows the other T-cells in the skin. And one of the technologies that can help identify whether that is the case is this technology called high throughput sequencing of the T-cell receptor. And to really kind of boil it down to a basic analogy before I throw up a slide is, if you can imagine two different jars of marbles. One of the jars has 3 total marbles in it, 1 blue, 1 red, 1 yellow. The other jar is 30 marbles, 10 of them blue, and then the other ones are all different colors. If blue represented the malignant T-cell clone, the frequency of that clone in either of those jars would be 33%. But what this technology is able to do, because we wouldn't necessarily know if we only focused on the 33%, is how many T-cells or marbles were actually in the jars. And what the sequencing allows us to do is actually quantify the number of T-cells in the biopsy, to be able to identify the malignant clone, and to be able to see and study if any of those features are actually predictive of disease progression. So, Mike, if you could put up that first slide.
Sure. Yep. Go ahead, it's up there. Go ahead, it's up there.
So when we were very young, potentially as a very early baby or even prior to that, we had T cells in our body that are there to fight infection. And before any of those T cells divided, we would have millions of T cells, all that were unique. And each T cell, at its initial ability of after it comes out of the thymus, has a unique fingerprint. And every time that T cell divides, that fingerprint is passed on to its daughter cell.
Return, period.
And so if one T cell is dividing more than other T cells, that fingerprint starts to become more prevalent in whatever type of compartment that you're looking at. So we are actually looking at the T cells in the skin. And what we are trying to do is identify each of the T cells by that unique fingerprint. And that's where the sequencing comes in. And it identifies that unique fingerprint. Instead of it being a marble color, it is now a nucleotide sequence that is unique to that T cell. But knowing the exact amount of DNA that we put in, we are able to then identify how many T cells are actually present and how many of individual T cell clones make up that tissue biopsy.
Audience.
And by virtue of that, we can actually determine the malignant clone frequency. And more importantly, the actual malignant clone, because the malignant clone is more highly prevalent compared to the next most prevalent clone. So if you think about a normal skin, what you would generally see is a nice stepwise reduction of the amount of T cells that were present in the skin in terms of frequency. When we are looking at a patient with CTCL, the malignant clone frequency is up here, and the next most frequent clone is down here. And that is how we identify the malignant clone frequency in our CTCL skin biopsy specimens. Okay. So that was a long-winded version for high throughput sequencing of the T cell receptor. The other technology that we're using is called multispectral immunofluorescence. If you can think of paint by color, in general, when we look under the microscope or we try to look at different cell types under the microscope, we use one or two colors. So if we were looking at paint by number, it'd be ones and twos, and it would be two colors that we'd be coloring with, and that's it. With multispectral immunofluorescence, we're able to actually look at up to 6 colors. And so that allows us to look at dynamic relationships, or I guess at one time period when we did the biopsy, spatial relationships of different cell types. And again, we hypothesize that those relationships between different types of T cells can actually be predictive of disease progression.
And you had a slide, right, of the...
I did.
Yeah. Mike, if you want to, can you throw that slide with the multicolored?
Yeah.
It was the third slide
Third
up there, so
slide,
people
sure.
can just kind of get a...
Sure, we've got the third slide up there right now. I don't know if you can see it, Dr. O'Malley, but
So
it is up there.
before we go, Mike, so let's stay on this slide for a second. So this is essentially kind of a readout of what the high throughput sequencing is, not the multispectral immunofluorescence.
Right.
However, what I wanted to show to the audience here is that the maroon bar that is so much higher, they all look like kind of skyscrapers. This is a city skyscraper type of graph, is so much higher than the rest of the skyscrapers. And the other skyscrapers that are not as high are actually the benign T cells, while the maroon skyscraper is the malignant T cell. And so that's just kind of an idea of how we identify the malignant clone.
Right. And then the next slide is the multispectral something or other.
Yes.
Hopefully you can see.
Multispectral immunofluorescence.
Right.
And so what we will potentially see are 5 different colors on the slide, and each color actually represents a different cell type. And the computer or the software that also comes with the microscope that we use is able to identify those cells and count them instantaneously, which allows us to get a lot of information in a very short period of time.
Wow, that's very exciting stuff. I mean, we're not quite ready for prime time yet, right? But the gist of what you're working on is leveraging this new technology that could potentially tell us more about an individual's disease, and then to really be able to tailor the treatment not only to the disease as it shows up, but also to what shows up in the underlying biology, and that piece of skin really that gets taken in a biopsy. Is that a correct wrap up?
Yeah, exactly. That's a very fair wrap up, is the fact that we can take one skin biopsy. And I think part of the importance of this study is potentially also looking at multiple if every skin biopsy is exactly the same, so that if we are making conclusions from the study that in general one skin biopsy is representative of the other skin biopsies is an important kind of side note to that study. But yes, it would be taking a piece of tissue that's the most characteristic lesion on that patient, and then ideally getting prognostic information to help guide them in terms of their risk of progression.
Excellent. So something exciting to look forward to, because I think, at least from my perspective, when people think about research, they think about new treatments and drugs that are in clinical trial. But this kind of research is also very critical, especially in our disease, because we want to try to figure out who has the potential to progress, to be able to get ahead of that, versus we just can't quite do it well enough today. So this is a really important part of the whole research landscape that's currently going on that most people don't really hear about.
Correct. Right. Yes. And gathering enough patients to actually be able to study is one of the biggest challenges. And what we have kind of found so far is that the malignant clone frequency, so going back to the potentially bad analogy of the marbles, though, is that the amount that the malignant T cell takes up in terms of the total T cell infiltrate does seem to be particularly prognostic for early stage patients, and more specifically in stage 1B patients, which is a big stage where 10 to 79% of their skin could be affected, that there's a lot of variability in outcomes in those patients. And so what we are excited about, and in full disclosure, our paper is under scientific review at a journal, so it's still a manuscript and has not yet been published. But what we are excited about is that it seems to be a very strong predictor, and a stronger predictor actually than the other prognostic markers that are presently out there, including the CLIPI score.
Cool. Excellent. Well, thank you for sharing that. And so switching gears to a whole nother topic that I know is near and dear to many people.
And actually, Susan, I was just going to jump
ahead.
in if I could. We did have a question that came in beforehand, not directly related to what you were discussing, but sort of related. You know, the amazing research that you shared, Dr. O'Malley, about sort of predicting which patients are more likely to progress. Is one side of the coin, but from the patient side, you know, there was a question from the audience in terms of, other than blood work once a year and trying to stay healthy, what can I do to help prevent the progression of this disease?
So, you know, listen to your body is, I think, the biggest recommendation that I could do for anyone, because I get this question a lot. And even prognostic tests are not perfect. So essentially what we are discussing, even with the research, is the risk of progression, is that you're at a so many fold higher risk than someone who didn't have a malignant clone frequency at 25%. So this is not a perfect test that is automatically guaranteeing that there's going to be a risk of progression. But in day-to-day clinic, when patients ask me this question, essentially your body can tell you a lot. So if your disease is starting to change, if your skin surface area, if you're starting to get a lot more rash, if it's starting to become itchy when it hasn't become itchy, if it's starting to become thicker and it never was thick before, or the classic symptoms that we discuss, fatigue, chills, fevers, night sweats, weight loss, those are things that you wouldn't want to sit on and think that it's going to get better. It would be good to alert your physician to that these are going on, so that they can take a look at you. And then general recommendations: try to get enough sleep, try not to stress. I know it is always stressful having the diagnosis of cutaneous T-cell lymphoma, but try not to stress, and to eat well. Mediterranean diet is always something that I recommend, that there's not any scientific evidence that it improves or decreases your risk of progression, but I think exercise and eating well at least will optimize how you feel about yourself, and will hopefully decrease the risk of disease progression.
Great, thank you. And I'll just invite everyone who's in the audience, if you have a question for Dr. O'Malley, to go ahead and post it below the video on the CLF Facebook page, and we'll do our best to get to everybody's questions. So, itch. Never an easy, always a question, never an easy answer. What are some of the first things that you share with your patients who might be experiencing the intensity of itch? And how can we as patients maybe do some things at home to help alleviate some of those symptoms?
Sure. So first and foremost, itch is a very, very challenging thing to treat. The good news is that if therapies are actually working to treat the CTCL, generally the itch actually is also treated. So that is generally the route that people go. But oftentimes the therapies take a while to work and the itch is not going away in the interim. So general skin measures include whatever topical treatment that we give you, it never hurts to continue to use moisturizer as frequently as you start to feel itchy. And then in terms of actual itch treatments, there's really many different pathways of itch. And often we rely or fall back initially on doing antihistamines for oral therapies when the topical therapies like topical steroids or Valchlor, the treatments that we use for CTCL are not working well for itch. Antihistamines do work occasionally, but in general, they are disappointing because the CTCL does not generally cause itch through the histamine pathway. There are other pathways that we can target, but most of the therapies that we have for itch are less than satisfactory. One of the therapies that I think can work well, especially in those patients with a burning type of itch or a pins and needles, is when they describe it, is gabapentin, which is a medicine that you take by mouth that we generally start at night, and then we can actually go quite high or up in dose in the amount of times that you're taking it, as long as you're not getting too tired or being knocked out or having other side effects from the medication. So that's what I like to use for kind of the burning / pins and needles type of itch. Then for patients who really have intractable itch and it's really affecting their quality of life, once itch starts to happen, it kind of becomes its own thing, and actually kind of the neurons in your brain, central brain, start to actually change a little bit. So there's some medications that can actually work on the neurotransmitters in your brain. And medications like mirtazapine or Lyrica can often be helpful in patients who have high degrees of itch, and nothing else that we've done in terms of topical treatments or even the systemic treatments have been touching it. And then the last medication that I'll touch on is a medicine called Amend or aprepitant. And that is a neurokinin-1 receptor antagonist or a substance P antagonist that helps also treat itch. It is taken primarily two different ways. One is either kind of 3 days in a row every 2 weeks, or sometimes you can get it taking it daily. It generally does work well for itch. However, it is extremely expensive, and oftentimes we have trouble getting it approved by insurance companies.
But there are some options, at least for folks. I mean, in addition to good skincare, and if they are still experiencing that intense itch, they should talk to their physicians about the possibility of using maybe one of these oral systemic medications that might help.
Yes. And then there are some other topical therapies like Sarna lotion, which has menthol and pramoxine, which can sometimes help calm the cutaneous nerves that are liking to become activated and itchy. But yes, I would talk to the physician. I have often found that it is completely individualized in patients. What some of these over-the-counter anti-itch treatments can work wonderfully well, and in other patients, they don't touch the itch. So it really is a personalized approach for itch.
Right. So we have to try everything kind of as our own special guinea pigs. Try everything that you can, and hopefully, try to find what works best for you.
Correct. And in general, the rule of thumb is start off with things that have very, very few side effects. And if you're always weighing quality of life and how day-to-day interactions are, how miserable you are with itch, and then we can go up that ladder in terms of therapies that could work extremely well, that may or may not have side effects. But we make that decision usually together after discussing those items.
Right, that makes total sense. So along the lines of skin and skin issues, infection tends to be a challenge as well, especially for folks that have a little more progressive disease, plaques, maybe tumors, or Sezary, where you might have some open fissures and things of that nature. So what kinds of things should folks be looking for or paying attention to keep from getting an infection, which obviously is not a good thing?
Sure. So there's a wide range of infections. And as you mentioned, the patients who have a little bit more or who have more advanced disease often have an impaired skin barrier. So they are much higher risk of getting infections for things like Staph aureus, which is kind of common throughout the environment, including MRSA. Viral, like herpes simplex virus, where a cold sore can actually start to progress to other places on the body if the skin is open, and fungal infection. So common foot fungus can oftentimes make the CTCL itching and rash occasionally much worse. And just treating the foot fungus can occasionally actually improve the rash quite a bit. So having good skin care. The other thing that I recommend in terms of infections, it's very hard to prevent infection. And we are always dealing with the possibility of bacterial resistance if we continue to use the same medications to treat infections. But in skin lesions that all of a sudden start to become oozing or have more fluid coming from them, I always recommend to make an appointment with your doctor to be evaluated, because those are potential signs of an infection, and a culture can be taken so we can make sure that we're treating you with the right antibiotic. And anytime that a new open wound that doesn't seem to be healing is occurring, I also recommend letting your doctor know so that they can evaluate and try to give you the best treatment possible for that.
So always a good idea to get a test for an infection so that you can actually manage that as well as the cutaneous lymphoma itself.
Yes, and occasionally if your doctor has given you some topical antibiotic ointment to be used when your skin does break open, or when patients are itching their skin and their skin happens to break open, that is okay to use if your doctor has said to use it. But occasionally, if that seems to stop responding or it just doesn't seem to be working quite the same, you may have bacterial resistance, and that would be a reason to get a bacterial culture, for instance, to check for that.
Got it. So before we let you go, I'd like to take some questions from the audience. Hopefully, Mike, do you have some questions for us? Great.
Yes, I do. I'm going to read those questions so we can get through them as quickly as possible.
Okay.
Some of these came in ahead of time, and I know I've shared them already with you, Dr. O'Malley, but for the benefit of the audience, somebody's mentioning that they think they saw in one of the Cutaneous Lymphoma Foundation newsletters a report from a fellow in your department at Harvard indicating that your experience with total skin electron beam radiation led to many remissions that lasted for as long as 5 years. Is that correct? And if so, why can't other institutions, and they mentioned one in New York, make that claim? My doctors can't really give me a good enough reason to really consider it. And another very well-respected hematologist-oncologist at another unnamed institution made a face when I even said that my doctors recommended it. If the Sezary count by flow cytometry test measures absolute clone size as very small, like, for example, 150 cells, and total skin electron beam radiation kills all the bad cells in the skin, would that be considered a remission? And can you predict how long that might last? So there's a lot of questions in there. I don't know if you can maybe touch on some of those.
So I think the best way to approach it in terms of the individual case and discussing, it's difficult without knowing all of the details. But what I would be happy to discuss is, in general, kind of total skin electron beam and where that fits in to our therapeutic regimen, and at least what the literature has shown in terms of effectiveness of that therapy. So we generally think of total skin electron beam therapy as a good therapy where patients have not been responding to typical frontline treatments very well. They have an extensive amount of skin involvement, and there really is no evidence of involvement in either their blood or their lymph nodes. Because when we are treated with electrons, they really only treat the surface of the skin. So they aren't going to be treating the blood disease, and they aren't going to be treating the lymph node disease. So in those patients who have extensive skin disease, who have failed other frontline therapies, the response rate is very high in total skin electron beam therapy, regardless of the dosing regimen used. And so there's a low dose regimen, and then there's a regular dose, which kind of ranges from 12 to 36 gray. Now, in patients with low dose, they do have extremely high response rates, but most patients do not experience 5 years of disease free. It is really dependent on the patient. So anecdotally, there are patients that have had complete responses for years after their total skin electron beam therapy. But the median duration of response, even with low dose, is still around 70 weeks, which is quite actually a long time. But it depends on the individual. Some patients will have a relapse much sooner than other patients. But again, it really, it needs to be kind of optimally chosen in terms of patients who have extensive skin disease, but not really evidence of blood or lymph node disease.
Okay, great. The next one, does narrowband UVB in the setting of targretin and the Sorlin-like med given for extracorporeal photopheresis actually kill the CTCL cells in the skin? Does it eventually lessen itching, and if so, when? And can you tell how much of a role the side effects of targretin play in the itching? Do topical steroids kill the CTCLs in the skin or just reduce the inflammation caused by them? Again, another multi-pronged question.
I think there was maybe 6 there out of that one. So
people are getting their money's worth.
Yeah, exactly. So what I gathered from that question, and then help fill me in, Mike, where I missed it, but is there evidence that narrowband UVB and or PUVA actually kill malignant T cells?
Right.
Okay. And there is evidence that does indeed occur from prior literature, that it can kill the malignant T cells. But the mechanisms also work in a variety of different ways, including suppressing inflammation and allowing your immune system to better react actually to the disease itself. Does bexarotene also help in that? Was part of the question, correct?
Yeah, targretin, bexarotene, right.
So that also has been shown that it can kill the actual malignant T cells. And from clinical evidence, the combination of lights and bexarotene is often much better, synergistic than either of those alone. Does bexarotene treat the itch, or is that part of the itch treatment? Is that next?
Yeah, they want to get a sense of can you tell how much of a role the side effects of targretin play in itching? So I think it's more, can it be a side effect? Is there maybe skin flares or itching as a result of being on that treatment?
So I'm not sure about that. With targretin or bexarotene, we're always concerned about the thyroid. Sometimes thyroid dysfunction can cause itch. But in terms of the actual phase 2-3 studies of bexarotene, it actually was itch. They actually did study itch, and itch actually improved. And there's also evidence that narrowband UVB can improve the itch. But in specific reference to a side effect from bexarotene, I can't really comment, and I recommend the patient to discuss that with his or her physician.
Okay, and then do topical steroids actually kill the CTCL cells in the skin, or do they just reduce the inflammation caused by them?
So that is a good question, and one that we are actually actively researching in our labs. And I forgot to say this earlier, but really a lot of this research is a joint project with my mentor, Dr. Rachel Clark, and the chairman of our department, who also runs the CTCL clinic, Dr. Tom Cupper. And then the prognostic stuff that I was discussing was also done in conjunction with a postdoc in Dr. Cupper's lab, Dr. Adele de Masson. So I have to thank all of those people as well about the research. But in terms of actual steroids killing the malignant T cells, It seems to kill both benign and malignant T cells that we see in the skin. So it is kind of a type of therapy that doesn't care whether you're malignant or not, but it kills both of them and it reduces the numbers. But we have not seen in our patients treated with steroids where it's getting absolutely rid of the malignant T cell clone. It's just knocking it down along with the benign T cells. But studies in vitro and prior studies have shown that steroids can kill a variety. T cells are very sensitive to steroids and can die from steroids.
Okay, great. We do have a few more questions. Do you have time for a few more, Dr.
Sure.
O'Malley? Great. We had that patient who had given us a long one about I have LYP for approximately 25 years with different
We did.
type
I think we
lesions.
answered that
You
one.
answered that one. Okay, thank you. I answered that offline. A few people on this forum had written that their stage of Sezary has changed with treatment. So in other words, if the treatment clears up the skin, their stage might be lower. For example, going from stage 4 to stage 3 or stage 2. If you look at the survival rates, stage really matters. So I'm confused on how a patient could go from a stage 4A to a lesser stage just because the disease is in remission. Can you, does the stage change at some point, Dr. O'Malley?
So it's an excellent question, and I think it is a point of confusion for some patients. So the initial studies, and when I was discussing earlier that stage is the most important prognostic marker that we generally use in a clinical day-to-day basis, is the stage at initial diagnosis. So very often, stage can change. In many patients, they can have their treatment is actually working, and so their stage actually becomes less. And in other patients where the therapy stops to work or there's a loss of response, you can actually increase in stage. But when we are discussing prognosis, it doesn't then automatically change to the stage that you become. We go by prognosis because the studies were initially done based on initial diagnosis and following those patients forward. And so that is why we talk about stage. But your stage can absolutely change during the clinical course and lifetime that you have with CTCL.
So, for example, someone with Sezary, if they go into remission with no sign of disease in their skin or blood, and they were diagnosed at stage 4A, where would that put their stage?
So, generally, we would say stage 4A CTCL patient in complete remission.
Okay. All right. And then
we would be very happy that they are in complete remission, but we would also still continue to follow them closely because we know that stage 4A patients have a worse prognosis than, for instance, stage 1B or 1A patients. And so we would continue to follow those patients because in general, there are no, well, not in general, there are no curative therapies in CTCL. And so generally it's time of remission, but it likes to come back, unfortunately.
Okay. Is there anything specific to look for when a Sezary patient contracts an infectious disease in their blood? My dad is currently admitted to Mass General with Sezary, pneumonia, and bacteremia. Hope I pronounced that right. Intense back pain and a swollen hand. The infectious disease team is doing everything they can to play detective, but I'd love additional thoughts from a Sezary specialist. Any thoughts on that?
So it's difficult to directly address this case, but patients with Sezary syndrome, what we do know is because of their impaired skin barrier, as well as the fact that they have a compromised immune system, they are at increased risk of infections. Furthermore, many of the treatments that we use in patients with Sezary syndrome, because we wanted to, but actually knock down the white blood cell count, making them even more at risk for infection. And so open wounds in the skin can be an entry point to become bacteremic, or meaning bacteria being present in your blood. And that is a very serious condition and requires generally admission to the hospital and treatment with intravenous antibiotics until the infection is under control.
Okay. And just a few more. Breast implant illness and undiagnosed, still testing for BIA ALCL. I was covered with lesions and the itching unbearable. I have several spots that reoccur. I had positive B cells. Would anything help with lesions? Many members of our groups have lesions and itching is horrible.
So what exactly is the question? So she's having itching and she has, and what I was a little unclear on is, does she have B cell lymphoma?
Let's see, still testing for BIA ALCL, but I was covered with lesions and the itching is unbearable. I have several spots that reoccur. I had positive B cells. Anything to help with lesions?
Got it. I think that is a question that is best addressed with the physician who is caring for him or her to figure out the best kind of treatment course, because you have to really understand everything that's been done to this point, including the extent of the lesions and what they look like under the microscope.
Okay. Just a few others. Is there research available of CBD oil treatment?
Is that a cannabinoid oil treatment?
I'm not sure. They mentioned CBD.
Okay. I'm not sure either, but not that I am aware of, if there's any research on that.
Okay. What approach should be taken with a diagnosis of follicular mucinosis on biopsy?
So follicular mucinosis is a finding that is seen under the microscope, where the hair follicle has almost a gelatin-like material called mucin. And it generally falls into kind of one of two categories. One is where they do a special test to see if there's a clone. And if there is a T-cell clone, so meaning that there is one T-cell that is outgrowing the other T-cells, kind of like what we talked about before, that can be a presentation of folliculotropic CTCL. In other cases where there is no clone that can be found, follicular mucinosis is a condition that we don't totally understand why it occurs, but we can use different type of topical treatment options, and we generally follow those patients because over time, sometimes, even though their original biopsy didn't show a clone, there can be a clone or a Mycosis fungoides type folliculotropic presentation in the future. So oftentimes with the diagnosis of that, it's kind of a watch and wait approach, treat it, but continue to follow the patient to see if anything else starts to come up on their body and can give us more information.
Okay, great. Well, I think, and yes, the follow-up, yes, it was cannabinoid treatment. So I think you answered that there was no available research to your knowledge. I think we have one last question here. If it's known that chemo doesn't work for cutaneous T-cell lymphoma, mycosis fungoides or Sezary, for example, then why does it seem to be on a protocol that you have to, quote-unquote, fail chemo in order to have a stem cell transplant? At least that's what's being offered to me. So could that be the use of the word chemo? Is that part of what's going on there?
So again, hard to comment on the specific stem cell transplant inclusion criteria or other criteria that they use to kind of say yes or no. But what I will say is that we do use chemotherapy in CTCL for advanced stage patients, and two of them that have good evidence of, or three, and probably more than I'm forgetting right now, but that show good evidence is gemcitabine, liposomal doxorubicin or Doxil, and pralatrexate or even methotrexate. And so those are actually chemotherapies that show evidence of efficacy or actually working to treat CTCL. And often those are therapies that we turn to when they're not responding to other therapies that we have. So that hopefully clarifies a little bit that chemotherapy is used. It just is, we don't as often in cutaneous T-cell lymphoma use a combination of multiple chemotherapies together like they do in other diseases.
All right. Well, that's great. Thank you so much for answering all those questions. I hope I got to everybody. I saw all the ones that came up on our screen here. If we missed you, we apologize. Feel free to post and we'll try to follow up. Susan, I'm going to toss it back to you to wrap it up.
All right. Well, thank you, Dr. O'Malley, for joining us tonight. And we really appreciate you're staying for a little longer. And I hope your son is still awake by the time you get home. So thanks so much. And I'll just let everybody know that we will be coming to Seattle for an Ask the Experts live event on March the 23rd. We'll be in Troy, Michigan on the 14th of April and in Denver, Colorado on the 28th. So those are the in-person live programs coming up. And then we will have Dr. Lauren Pinter-Brown with us next month for our Facebook Live interview to talk about when you should see a hematologist versus a dermatologist when you're dealing with cutaneous lymphoma. So with that, I will sign us off. Thank you again, Dr. O'Malley, and
thank you,
have
Susan.
a
I
great
just
evening.
wanted to put one plug in, but for the Cutaneous Lymphoma Foundation, a lot of the research that I discussed tonight was actually able to be done because of the generous funding of the Cutaneous Lymphoma Foundation. So I can't help but thank the foundation for getting this project off the ground. And then secondly, for the actual CTCL patients that we care for. They're a very, very generous group, and none of the findings that we don't have great animal or cell line models, and so a lot of the findings that we can get a better understanding of this disease is from the patients. And so the generosity of the patients, I'm always amazed at the group of patients that I'm privileged enough to take care of. And so thank you to the patients as well.
Thanks. And on that note, we'll sign off for tonight and wish everybody a great week, a happy Valentine's Day, and we'll see you next month or on the Facebook page. Send your questions. So thanks, everyone. Have a great night.
Thank
Bye.
you.